Welcome, everyone. Welcome. Everyone is joining. Welcome to our webinar. To start off, can you let us know in the chat where you are joining us from? We have a global community, so it's always fun to see where everyone is. Anna is joining from Cambridge. I'm joining from Boston. We have someone from Providence, Paraguay, Ecuador, London, Detroit, North Carolina, amazing New York. Got some of Evan's cohort mates supporting here, which is fantastic. Love to see it. Florida, Fall River, Mass, Dubai. Amazing. We'll just wait one more minute for people to join and we will get started. Amazing.
Okay, I think
Well,
the majority of the participants in. I can start with a very brief introduction. This is one of our many SUD Ventures related webinars we've hosted over the last 9 months. I am very excited to have our guest today, Professor Kharasch, who is also an SUD Ventures graduate, just like the previous speaker, Brandy Fink, who was also an SUD Ventures graduate from cohort 2. So we really are, as you can see, trying to also connect the cohort participants with the broader community. Professor Kharasch is a distinguished professor of anesthesiology at Duke University. He is an active clinician. He is going to tell you all a little bit about himself. So I don't want to steal that from him. Just wanted to share that he came to the program with a special technology in mind, and it's related to managing recovery from and treating fentanyl use disorder. Obviously has potentially other applications, but this is the specific angle that we're interested in for this webinar. And he's going to share a story about how he's currently going about from the very early stages of commercialization to try to take it to market. So, Professor Kharasch, I'd love to welcome you on stage. We will have the panelists talk about his work first, but if you have any questions, please share them in the Q&A section, preferably, of the webinar control panel, and I will be moderating them afterwards. We'll have plenty of time. I think the benefit of this sessions is that we get you to talk directly with all of the speakers. All right.
Anna, thank you very much. I very much appreciate the opportunity to join you and speak to the audience. I'm a very proud graduate of the SUD Ventures program. I learned a tremendous amount that has been helpful to me in my journey, and cannot recommend it highly enough to anybody else who wants to take that similar journey. And I want to ask a simple question. What if we could improve the existing treatments for opioid use disorder to be more effective? And that's the driver behind what I'm going to speak about today. I'm going to give you a little bit of background about me. I'm a practicing anesthesiologist. I've worked with opioids clinically for 4 decades. I've been researching opioids for many decades. I'm also a basic and clinical pharmacologist and do research in the area. Published more than 330 peer-reviewed publications. I've had several decades of United States government federal research funding, and I owe a tremendous amount of gratitude to the National Institutes of Drug Abuse, which has funded a lot of my work, NIDA. I'm somewhat of an academic innovator or entrepreneur in the sense that in one of my prior roles, I was a university vice president and was tasked by the university president with making the university more innovative and entrepreneurial. So I came at that from a leadership perspective, and here I am now coming at it from an individual faculty perspective. So it's interesting to see how the venture looks top down versus bottom up. Just to tell you, I am not a clinical addiction medicine specialist. I don't treat patients with opioid use disorder other than the occasional surgical patient that may come to the operating room who has this clinical problem. And I'm not a business entrepreneur per se, but I'm hoping to be one. So the things that I want to cover today are essentially threefold. One is talking a little bit about the unique challenges of treating fentanyl use disorder with the existing medicines that we have. One of those is the drug methadone, and to ask how can we repurpose or improve methadone to improve its clinical effectiveness in treating fentanyl use disorder. And then lastly, what are the next steps along the journey, and what are the challenges along this journey in moving our attempts to improve methadone pharmacology forward, and how do we commercialize this clinical idea? So let me start with the opioid crisis. This is something that we hear about a tremendous amount in the medical press, in the lay press, but the details really aren't well known. And I just want to give a little bit of a grounding so that we understand the focus of what we're trying to do. And I'll talk about 4 waves. The first is that for thousands of years, we used opioids to treat pain. And in the 1960s, 70s, 80s, treating pain with opioids was the norm. They were among the most widely prescribed drugs in clinical medicine. That use expanded even more in the 1990s as we paid more and more attention to the undertreatment of pain and the need to treat it better. And we were treating it with more opioids. We used it for acute pain, chronic pain. And then in medicine, we invented something called the 5th vital signs. Vital signs are things like heart rate, blood pressure, temperature. Well, we added pain as the 5th vital sign, which then meant that not only did we have to pay more attention to it, but we were treating it more, and it was being treated with more and more opioids. After the turn of the millennium, we further expanded the use of opioids for treating pain. Managed care programs really encouraged the use of opioids to treat pain and get patients out of the hospital faster. Treat patients with opioids to get them out of the emergency department faster. This was all around greater practice efficiency. Opioid costs fell. The federal government in the United States even supported the price of opioids to expand their use. We then had problems with the recession in 2008 with economic crisis, stagnation. A lot of people were unemployed, and suddenly we started seeing opioid abuse and deaths associated with opioid abuse. And that was really the seminal event. The other thing we saw is that pharmaceutical companies were very, very aggressively marketing opioids, and in some cases they were doing it deceptively and illegally, and there were a number of companies that were sanctioned and fined very heavily for inappropriately marketing opioids. And now what we started to see was the intertwining of prescription opioid use and heroin use by people who were habituated to prescription opioids but really couldn't get them. And then the most recent wave was after the recognition that what we were doing was very well intentioned, but not well executed, and was associated with very substantial problems, was that the opioid supply was markedly contracted and shrunk. There was prescribing prescriptions, supply restrictions. There were a lot of hospital, local, state, federal regulations which restricted the prescribing and the use of opioids. And then what happened is that the users of prescription opioids and the supply chain shifted. And it shifted from prescription opioids to illegal or illicit opioids. People are intrepid, and if they're looking for pharmacology, they will find it, and markets will respond. And what we've seen is the increasing availability of illicit fentanyl. And that fentanyl is now the substitute for prescription opioids. And you've all heard about the problem with fentanyl, and that's what I'm going to talk about today. And what really happened is that a lot of those overdose deaths that were due from prescription opioids have now been replaced, unfortunately, by overdose deaths from illicit fentanyl. So in a sense, the opioid crisis really migrated to something that we call the fentanyl crisis, or the illicit fentanyl crisis. Fentanyl is a very, very effective drug. We use it in medicine, and particularly in anesthesia, all the time. The problem is with illicit fentanyl. And just to give you a perspective, this is what the lethal dose of fentanyl looks like. It's very, very potent. Just 2 milligrams, that little tiny bit which fits on the tip of a pencil, is enough to kill somebody. Now, one of the reasons that we have such a fentanyl problem is that in a very strange way, there's a business case for illicit fentanyl. There's a tremendous demand for it. There's a very available supply, and it's very profitable. On the left at the top, you see some photographs of what an oxycodone tablet looks like. On the right is an illicit or counterfeit oxycodone tablet that contains fentanyl, and it's very difficult to tell the difference. Fentanyl is relatively easy to make. You can make 1,000 grams or 1,000,000 milligrams of fentanyl for about $4,000. You can sell it for about $10 million on the street, which is a 2,500-fold return on investment. And in a sad way, that's a very, very profitable business. As you know from the lay press, there's thousands of pills of illicit fentanyl which are coming into the country and other countries on a daily basis. And it's not just the counterfeit pills, but so many of the other street drugs which people use today are adulterated or laced with fentanyl as well. Cocaine, heroin, marijuana may be contaminated with fentanyl, and those drug users may not be aware of that. This is a slide which shows you the seizures of illicit fentanyl by the United States government over the course of the past decade or so. And on the left, you see the kilograms, thousands of grams of fentanyl powder that have been seized every year. That represents billions of those 2 milligram doses. And on the right, you see the number of illicit fentanyl-containing pills that have been seized by the United States government. And 70% of the counterfeit pills that have been tested contain a lethal dose of fentanyl. So the use and abuse of fentanyl is now what has replaced the opioid crisis with the fentanyl crisis. And this is why we have so many individuals who have fentanyl use disorder. We have something called the opioid paradox. The opioid paradox is that physicians have been hearing that they need to decrease opioid prescribing, and they've done that. Opioid prescribing has decreased by 50% over the course of the past 15 years, but opioid deaths have increased by 355%. And you see that in the blue line in the graph. Those are the opioid, in the red is opioid fatalities, in the blue is fentanyl fatalities. And what you see is that more than 90% of all opioid overdoses today are caused by illicit fentanyl. So it's really illicit fentanyl that is the major public health problem when it comes to opioid abuse. So let me switch to, how do we treat opioid use disorder and how do we treat fentanyl use disorder? Well, there are basically 3 drugs that are available in the United States and worldwide to treat opioid use disorder. These drugs are called methadone, buprenorphine, and naltrexone. Now, fentanyl use disorder is particularly hard to treat. Buprenorphine and naltrexone are not effective in treating fentanyl use disorder because they can actually put patients into withdrawal, which is the very thing that we are trying to avoid. The primary drug for treating fentanyl use disorder is methadone. Methadone is a drug that's been around for 75 years. It's been used to treat opioid use disorder since the 1960s, and it is very effective in treating fentanyl use disorder. It saves lives. It reduces patient cravings. It prevents withdrawal from patients who are habituated and addicted to fentanyl. It also has collateral benefits because patients may use less intravenous drugs. It decreases the transmission of infectious diseases like HIV and hepatitis and sexually transmitted diseases. It definitely decreases the risk of overdose and overdose deaths. And methadone is used to treat fentanyl use disorder in 2 ways. It's used for what we call induction or initiation, and that is when we first encounter individuals who have fentanyl use disorder, how do we get them started and stabilized on methadone? And then we also use methadone for maintenance. How do we keep them in treatment for opioid use disorder? How do we prevent them from stopping their methadone treatments and going back to using fentanyl? And then the other thing about methadone is that it is underused. Only about 20% of the patients who need treatment for fentanyl use disorder are currently treated for fentanyl use disorder in the United States. So in many ways, methadone has been very effective, but there are barriers to success. There are unmet needs, and there's room for improvement. So let me visit some of those with you. Let's look at how we use methadone for initiation or induction and titration or dose adjustment, if you will. And what are these barriers to success? Well, typically, patients are hospitalized in order for induction therapy to occur, because they need very close supervision and monitoring. Methadone, when it's given orally, has very slow absorption. It has variable absorption, meaning a lot of interpatient variability, which means that when you want to start dosing patients on methadone, you have to start with a low dose and you have to go very slowly in terms of increasing the dose. Guidance documents suggest that you should only increase that dose every 2 or 3 days, which means that it can take days or even weeks to stabilize patients on methadone when you first start them on therapy. The other thing that can happen is that because you have to start low and go slow, some of these patients can actually go into withdrawal because we're not keeping up with their addiction. That withdrawal process is extremely unpleasant. It's extremely uncomfortable. And patients may become so disenchanted with that process that they may just drop out of their entire induction process. They may leave the institution against medical advice because that withdrawal is so unpleasant. And lastly, this is particularly challenging in women who are pregnant and habituated to fentanyl because the behavior of methadone is different in pregnancy. It's eliminated much more quickly, which means that you have to work faster to get them titrated, but you're still held back by these guidances which say start low and go slow. So what is the unmet need? Well, let me pose this as a question. What if we could accelerate the process of induction and titration? What if we could prevent withdrawal during that induction process? What if we could shorten that induction time from weeks to just a couple of days? We could get patients stabilized faster. Maybe we could get them out of the hospital faster. Maybe we could improve that rate of treatment retention, keeping them in treatment longer. And perhaps we could even improve patient satisfaction. That's one of our goals. So that's the unmet need and the goals for initiation therapy. What about the unmet need and goals for maintenance therapy once we get patients stabilized on methadone? Well, we have some barriers to success there. In the United States, methadone can only be dispensed and administered by certified opioid treatment programs, or methadone clinics. There's only 2,151 of them in the United States. That may sound like a lot, but it means that some patients may have to travel very far every day just to get their methadone dose, because methadone treatment requires what we call daily observed therapy. Individuals have to be given their daily methadone dose in a treatment program, and they have to be observed while they take that methadone dose. Now, there has been some recent flexibility in allowing a little bit more take-home dosing of methadone, but it is still largely restricted to only a very few weeks of dosing. There's barriers to the opioid treatment programs. They have very limited hours. They may be very far away. There may be long travel times. There may be substantial transportation needs on the part of these patients who can't get to the clinic. And the fact that they have to go to the clinic every day means that this interferes with work or school, and it's inconvenient. We always talk about the goal of meeting patients where they are, if you will, but making patients travel to methadone clinics is really not meeting them where they are. And frankly, standing in long lines for long periods of time in front of a methadone clinic is very stigmatizing to patients. And treating fentanyl use disorder is particularly challenging when patients are, or individuals are, incarcerated, because jails and prisons just are not set up to be methadone treatment programs. So let's dream. What if we could improve the retention of individuals in methadone maintenance? Right now, the majority of patients drop out of therapy after just a couple of months because of the inconvenience. What if we could make it much more convenient for them so that they will stay in therapy longer? What if we could improve the concept of patient-centered therapy? Let's put patients first in treating their fentanyl addiction. What if we could improve the strategies for more take-home dosing? If the fear is that we give patients too many doses and they might not use them appropriately, what if we only needed to give them a handful of doses to take home that could last for weeks or even months? And lastly, again, improving patient satisfaction. So our strategy is really the reformulation and the repurposing of methadone. Methadone is already approved for treating opioid use disorder, but what could we do to make it better? Well, we have two ideas, or two product ideas. The first is what we'll call rapid onset methadone, and the second is what we'll call longer duration methadone. The idea for rapid onset methadone is a reformulation. We would reformulate it to make the absorption very fast and very predictable. So instead of taking 4 hours for the peak of methadone absorption to occur, we could make it occur within 10 minutes. We've already done the clinical trials, which have proven that our reformulation works. and it achieves that very, very rapid absorption and effectiveness. Because it's absorbed so much more quickly, we can titrate and adjust dosing much more quickly. Instead of waiting days to increase the dose of methadone, we might be able to give a second methadone dose within an hour. So we can shrink the time scale of initiation from weeks to days, or perhaps even hours. We get better therapeutic concentrations and we get them much more quickly. We can also prevent that acute withdrawal during the induction process. Ideally, we'd like to be able to achieve better retention in therapy for opioid use disorder. And if we can get patients stabilized faster, we can get them out of the hospital and back home or back to work faster. Our second idea is to make methadone last even longer than it currently does. And again, this is a reformulation concept where now we're looking to slow the metabolism of methadone, and we're hoping that this will translate into slowing the elimination of methadone. And let me put some numbers to this for you. Methadone has what we call a half-life, meaning how long does it take for blood concentrations to decrease by half? Right now, that's 1 to 2 days. Now, in the world of pharmacology and opioids, that's a very long period of time. But our strategy is that we could change it from 1 to 2 days to 3 to 4 days, or maybe even longer. So instead of requiring daily dosing, maybe now we'd only require weekly dosing. And think about the advantages of that. Certainly, greater patient convenience. What if they have to come to a clinic once a week instead of once a day? Certainly, there would be less stigma involved in treating fentanyl use disorder. It would be patient-centered. We could give more take-home doses because of the safety of a smaller number of doses lasting a much longer period of time. And there might be advantages to opioid treatment programs in general. It would be certainly less expensive on a per-patient basis to treat them once a week instead of once a day. And instead of treating patients once a day and now treating them once a week, these opioid treatment programs can accommodate or could accommodate many, many more patients in treatment. So these are our thoughts around the reformulation and the repurposing of methadone, rapid onset methadone and longer duration methadone. We think of these as two different products, although possibly we might be able to incorporate them together into a third new product. There may also be some what we call collateral benefits from these new formulations. And this collateral benefit might be applicability in treating pain, because methadone not only is used for treating opioid use disorder, but methadone is very effective in treating pain as well. Well, what might we do with the rapid onset methadone? Well, we might be able to use it for acute pain treatment. And it would be acute pain treatment that has fast onset and lasts much longer than any of the currently used opioids to treat acute pain. This might have applicability in emergency departments, might have applicability by in-the-field pain treatment, emergency medical technicians, and certainly in defense applications and battlefield injuries. To give you an example, in the United States, there's 140 million visits to emergency departments every year, and about 6% of them end in a prescription for take-home opioids. Many of those take-home opioids are unused. They sit in medicine cabinets where they are not appropriately stored, and they're subject to potential misuse. Well, rapid onset methadone might be able to be given as a single dose in the emergency department where we wouldn't have to send patients home with any opioids at all because of the fast onset and the long duration. What about longer duration methadone? Well, this too might have applicability in treating acute and chronic pain, might have applicability in treating post-operative pain or post-surgical pain, where so many patients go home with a large number of opioids, which are, again, not always taken. In fact, they're usually not all taken. They sit in medicine cabinets where they're not stored safely, and they're subject to misuse or abuse. And perhaps the longer duration methadone could be used in treating chronic pain as well. So this isn't our primary driver, but it's certainly, we think, a potential collateral benefit, which would impinge upon the, quote, opioid crisis, because we take a lot of opioids out of the system. We treat patients better, we treat pain better, and there's less potential for ongoing opioid misuse. So that's our journey so far. I've been involved in methadone clinical and basic research for more than 20 years. I've lived within what I like to call the NIH funding ecosystem. The National Institutes of Drug Abuse has supported my research for a couple of decades, for which I'm very appreciative, and it has transformed the use of methadone clinically in many ways. But just a couple of years ago, I had what I called the aha moment. So much of what we do in academia is academic research, but we had the realization that what we were doing academically might have commercialization potential. And it's really only through commercialization that research improves patient care and patient health on a large scale basis. As a colleague of mine likes to say, a paper in a journal never cured anybody. It's really only until that new knowledge reaches commercialization that it has benefit to the public at large scale. As Hannah noted, I was a participant in the MIT SUD Ventures program a couple of months ago, and after thinking about this for a couple of years, my participation in the program really moved my needle, if you will, and convinced me that this is an idea which we think is worth trying to move forward to commercialize and to achieve the public health benefit which grounds the research that we do. So for the past couple of months, I've identified three major goals. One is to pressure test the concept of our reformulation. And this has been involved in talking to as many people as I can to do primary market research, if you will. Is this a good idea? Talk to people in the substance abuse community, talk to people in the pharmaceutical community. And I can share with you that the reception to the idea has been uniformly very positive. Other next steps. One is company formation and identifying and capturing the capital to move this forward. I'm at the stage where we haven't yet formed the company because our next greatest need is a co-founder to do this with. I learned many, many years ago that academics shouldn't go start a business, but academics should partner with entrepreneurs who know how to found a business. So in a sense, I'm looking for a co-founder and a CEO to take the next step and who will also help us along the journey of capital formation. So science is really, really hard. But compared to starting a business, science is somewhat easy. The pharmacology of reformulating methadone is somewhat easy compared to our next challenge, which is starting the business. So I really appreciate the attention and listening of all you out there. If any of you have any thoughts, any suggestions, wisdom, or guidance, if there's any entrepreneurs out there who think that this might be a good idea and might be interested in co-founding the venture, my email is listed at the bottom of the slide. And I'll thank you for listening. And now I'll turn it back to Hannah. And I'm happy to take any questions or listen to any comments that any of you have. And so, Hannah, thank you, and back to you.
Yes, thank you, Evan. It was very well presented. Thank you, and very engaging. So yeah, if anybody has questions, we can also bring you in, but it would be helpful if you share them in the Q&A section. I do see 2 questions already, and we'll just stay here as long as we have up until 12, but we can leave whenever we're done with all the questions. So I have 2 questions from Marina, and I'll take them first. So Marina Kataeva, she is asking first, and I don't know if you can see them, Evan, do clinicians need quantitative information of fentanyl presence in the human to start treatment and monitor? And sort of a follow-up of this first question is, will it help to have rapid diagnostic device to know exact amount of fentanyl in the patient? What kind of technologies exist right now?
2 very good questions. And the first question is do clinicians need quantitative information about fentanyl presence in order to start treatment and monitoring? And I will have to admit that that falls into the category of actual treatment of opioid use disorder. And I don't treat those patients. So I unfortunately would have to defer on that question. The question of monitoring the absorption of methadone, we currently don't monitor blood concentrations of methadone when we dose methadone. We rely on patients to tell us if they're having symptoms of withdrawal, and we rely on clinical signs and symptoms to identify that patients may be getting too much methadone. And that's one of the beauties of the drug, is that there's enough safety involved that we don't have to draw blood concentrations and measure them on a ongoing basis.
Mm-hmm. And follow up to that is, how do you monitor, again, if you're not aware of that, that's fine, but how do you monitor the absorption of methadone, long and a rapid onset in this situation?
Well, from a research perspective, and I'll separate out, there's what we'll call research, and there's what we'll call drug development, and then there's clinical applicability. So in the realm of doing research and in the realm of drug development, we would monitor blood concentrations of methadone as part of that research and drug development process. We wouldn't necessarily do it as part of the clinical use process, because we can, once it becomes approved, and hopefully it would be, clinicians can rely on signs and symptoms from patients to know if they need more or they need less. So right now, we don't monitor blood concentrations of methadone, and I don't think that we would need to as part of this process.
Mm-hmm. Thank you. So we have a few international participants here in the beginning. I saw many different countries represented. And there's a question from Yukabeth Kaboya from Kenya. He's saying that in Kenya, we basically compound methadone and use it for other opioid use disorders. So yeah, just wondering if there are other resources that they can read and learn from.
Well, it's a very good question. And I think implicit in your question is that these are not problems which are limited to the United States. These are worldwide problems. And I'm aware that there is substantial opioid use disorder in Africa. In a process of commercialization, one of the first things that you do need to do is to protect the intellectual property, because in order to create a business and meet market needs, investors need to know that their investment would be protected. So right now, we are in the stage of protecting our intellectual property. We've applied for a patent on the long duration methadone. We're in the process of applying for a patent for the rapid onset methadone. So at this point in time, the science has to remain in the realm of what we'll call secret sauce. And it's only after we get that intellectual property protection that we can start to make that publicly known within the restrictions of what you have to do when you create a business. But we're very cognizant of the potential that these ideas have worldwide application. And once we advance them, frankly, there may be additional resources to move these ideas forward in terms of entities such as World Health Organization or potentially Gates Foundation to bring resource to make these concepts more publicly available.
Thank you. Thank you. Adam Sibley is asking about whether you have any plans to account for patients using fentanyl with xylazine and methadone. I'm not sure I know how to pronounce this, who may separately experience withdrawal symptoms from these sedatives.
Very good question. And you know, fentanyl is an opioid, and the drugs xylazine and medetomidine are actually animal tranquilizers. These are not drugs which are approved for human use. They are approved for veterinary use, but suddenly we are seeing fentanyl co-abused with xylazine and medetomidine. Now, the countermeasures for fentanyl, like methadone, are different than the countermeasures or the antagonists, if you will, for xylazine and medetomidine. It's very different pharmacology. Now, it might be possible to co-formulate the antagonists of fentanyl and the antagonists of xylazine and medetomidine. We haven't explored that at this point in time. That's a little bit even more of a complicated story, if you will, because now you're combining drugs. You're not just working with a single countermeasure, if you will. So, Adams, it's a very good question. It's one which I've thought about. It is an unmet need, but that's an even more advanced challenge that we would want to take on after we take on these two co-formulation challenges.
Thank you. Sudhakar, I think part of the cohort too, is asking about whether there has been proving of the two product concepts in terms of efficacy. So have they been tested? Is it safe to use this? What are the side effects of the two approaches that can be considered risks to humans?
Excellent question. So right now, when I refer to pressure testing, that's a comprehensive concept. I used it in the context of talking to people who are experts in substance abuse disorder and medications for opioid use treatment, talking to people in the pharmaceutical industry about the concepts. The broader application of quote unquote pressure testing is actually clinical testing. So the rapid onset methadone concept has been clinically tested from purely a drug development perspective. It hasn't been yet clinically tested from the perspective of fentanyl use disorder. That would be part of the commercialization pathway or the drug development process. The ideas around the long duration methadone at this point in time are laboratory ideas. We've done all of the laboratory testing. We've done a lot of modeling and simulation of what would happen clinically, but we actually haven't done those clinical studies yet. Those clinical studies also would be part of that commercialization pathway. But I think that one of the things I've learned from talking to experts is that they believe that the regulatory pathway for these ideas might be relatively fast. Now, when we talk about the drug development process, very often some of the early steps in the drug development process are simply doing the studies where we give drugs in development, and then we measure blood concentrations to see if they're meeting the needed blood concentrations. And then we move on to the clinical patient studies. Well, because methadone is so well known and we're so well experienced with it, many experts in the field believe that simply doing those blood concentration studies may all be that's needed to get regulatory approval, and that we can, in a sense, substitute those studies for big clinical studies, which means that the development pathway might be a year or two and a few $1,000,000 rather than a decade and hundreds of millions of dollars. But I'd like to find out if that, in fact, will be true.
Yes, that's very important. Another question is from Habenam. I'm not sure I quite understand it, so I'm just going to read it out. Methadone is synthetic opioid, and so does fentanyl now. Wouldn't be sort of rotation or substitution? I guess talking about not methadone addiction here. I'm not quite sure. Habenam, if you're here, maybe we can bring you to clarify.
Well, in treating pain, cancer pain, for example, sometimes clinicians will do what's called opioid rotation. So if somebody's been on a particular opioid for weeks, months, or years, they might switch to a different opioid. And so one of the processes is that sometimes patients who are on one of the commonly used opioids might get switched to methadone. That does happen from time to time. And that might be an area in which the long duration methadone might be attractive for those cancer pain patients. But again, that's a clinical study that needs to be done.
Thank you. With the change in dosing frequency, this is a question from Kenneth Richmond. How are OTPs adjusting to meeting the client's requirement for therapy?
Well, right now, we haven't implemented this in opioid treatment programs. We haven't yet developed the commercial products. So we don't know how opioid treatment programs would adjust. I think that once we understand exactly how the long duration methadone would last, whether it would be dosing of twice a week or once a week, I think at that point, when we get a better understanding, then the opioid treatment programs could adjust dosing frequency.
So several questions here, a bit more about the risks. Sahar S. Harati asks, thanking you for the presentation, and is wondering about whether the rapid absorption of methadone, if there are any risks of addiction. And then Dr. Aditya KNV is asking about whether, what are sort of the common mistakes clinicians make while using methadone?
It's a very good question. Many years ago, about 2 decades, there was a push to use methadone in treating chronic pain by primary care providers, family medicine doctors, generalists. As identified, methadone can be a complex drug to use. And those decades ago, what we found was that those primary care practitioners who didn't necessarily understand the nuances of using methadone were giving it more frequently than they should have been. And some of these patients ran into trouble because they were suffering from, in a sense, an overdose of methadone. Now, that was recognized, and so that drug is not used anywhere as frequently by primary care providers for routine pain treatment. But with any opioid, there are risks of giving too much. We know this from medical press, from lay press. As an anesthesiologist, my specialty is grounded on the idea of knowing exactly how much opioid to use in any given patient. One of the attractive features of using methadone is that when it's used appropriately, it is very safe.
Thank you. A question from Evan Hitch. I believe he's also one of the graduates of the program. What have you seen the primary barrier to be for hospitals to provide methadone taper? And there's some background to his questions. He's sharing that throughout New York State, some hospitals who provide opiate detox have begun implemented this rapid methadone taper, but it hasn't really taken off. He believes this has been an effective approach, and some other details that he's shared about how that might actually sort of hospitals may prefer Suboxone or
That's a really good question. Because of the challenges of initiation or induction therapy, a lot of practitioners and institutions are trying to get this done in a faster way. They're developing their own approaches and protocols. I'm in communication with many of them who've sent me their homegrown recipe, if you will. And those homegrown recipes are very well intentioned, but they've not really been rigorously tested. And so it's a little bit of the Wild West out there. You're still limited by the fact that methadone has very slow absorption when it's given orally, and it's highly variable. And so right now, it's a tremendous institutional or individual variability in how practitioners are approaching the induction of methadone therapy in fentanyl use disorders. We're still limited by the basic formulation that we have. So I think that the improvement will come not by coming up with a better approach, because we're limited by the drug that we have, but rather using an improved formulation to make it behave more like the kind of drug that we would like to have. And as far as programs using buprenorphine, that's very tough with fentanyl, because, as you know, buprenorphine is a drug which will also antagonize the effect of fentanyl. And if you have somebody who comes in and they're habituated on fentanyl and you give them buprenorphine, you will send them into withdrawal. We just can't use buprenorphine for initiation of fentanyl use disorder.
Thank you. Two questions I think that could be grouped together from Javed and from iPhone 12. Sort of, what are the measures, significant changes in biometrics, such as heart rate variability, blood pressure fluctuations, body temperature irregularities, that have been consistently observed during the various stages of methadone withdrawal? What are some of the underlying physiological mechanisms driving these changes? And then how long should a patient be on methadone for OUD? Some patients have been on them for 2 years, and it seems like they're not ready for moving.
Good question. Again, I'm not a practitioner in addiction medicine, but I just know as a physician that some of the signs and symptoms of opioid withdrawal are nervousness, anxiety, increases in heart rate, increases in blood pressure. sweating, pain, and one or more of those things can happen in patients who are undergoing opioid withdrawal, none of which are pleasant for patients.
And in terms of methadone withdrawal, do you have any experience with that, or would it be better to ask an addiction medicine?
Again, clinically, I don't treat opioid use disorder. So I personally don't see patients who are going through withdrawal. My knowledge is through a lot of communication with practitioners who are addiction medicine specialists, and they've shared with me the problems that they have and their frustrations in the tools they have to treat patients who are withdrawing from or habituated or addicted to fentanyl.
Thank you. And looks like these are most of the questions. If anybody else has questions, we have maybe time for one more, but otherwise it has been very, very informative. Thank you, the audience, for being also so proactive. If anybody is interested in the space or knows somebody who's interesting to take and has the expertise to take this technology to market, definitely connect directly with Professor Kharasch. Thank
Any
you.
other questions? Or are we good?
I think we're good, and we're
All right.
on time.
One last time, thank you all for listening, and thank you for great questions.
Thanks. Until next time.
Thank you, everyone.
Bye-bye.
See you next time. Thank you, Evan.
Thank you all.